today is Ashia Hackett, who is a general surgery prelim resident here at Sinai and has spent the last 2 weeks with us on service doing a sub-I. She completed her undergraduate degree at Spelman College in biology before getting her medical degree from Ross University. She then completed a research fellowship at the Barrow under Dr. Lawton before starting her internship in general surgery. She'll be presenting to us today on the topic of racial and socioeconomic factors on aneurysm outcomes, a single center study.
Hello, let me go ahead and share my screen. All right, can you guys see it okay?
Looks good.
All right. So yes, my name is Ashia Hackett. I'm currently a general surgery prelim, but I spent the last year at Barrow where I completed this work that I'll be presenting this morning. The title of my presentation is Unmasking the Impact of Racial and Socioeconomic Factors on Intracranial Aneurysms, and this is a single center study. I have no disclosures. So intracranial aneurysms occur in about 5% of the population. Rupture of these aneurysms leads to subarachnoid hemorrhage, which is an urgent medical condition associated with high rates of morbidity and mortality. It is estimated that around 0.3% of unruptured aneurysms lead to ASAH annually, but the majority are incidentally detected due to improved imaging techniques and more frequent use of neuroimaging. Despite these advancements, certain racial and socioeconomic groups continue to be disproportionately affected by the disparities in detecting and addressing aneurysms prior to rupture. So the present study aimed to analyze the patient demographics of individuals who underwent microsurgical treatment for unruptured and ruptured intracranial aneurysms. And we hypothesized that individuals from non-white racial backgrounds and individuals from low SES groups suffer from ASAH at a disproportionate rate compared to those with UIA. All patients who underwent microsurgical treatment for an intracranial aneurysm over the span of 5 years were included in the study. Ethnicity was categorized based on the US Census definitions, and then socioeconomic status was determined using the patient's home address, which we then put into the neighborhood atlas, which provides an area deprivation index based on income, education, employment, and housing quality. From there, we categorize these patients into 5 SES tiers, with tier 1 corresponding with the least disadvantaged and tier 5 with the most disadvantaged. We then did descriptive and comparative stats where we identified the differences between the ruptured and unruptured groups. And then I employed a binary logistic regression model, which was used to predict the clinical presentation of ASAH based on socioeconomic factors while adjusting for age, gender, comorbidities, and aneurysm characteristics. Here is a table explaining the univariate analysis. So race and ethnicity showed a highly significant association with aneurysm rupture at a p-value of less than 0.001. And the unruptured group had a higher proportion of patients classified as white, while the ruptured group had a larger representation of non-white cases. As far as socioeconomic tier, that also demonstrated a significant association with aneurysm rupture presentation. The unruptured group had a higher proportion of cases in the least disadvantaged tier, SES tier 1, compared to the ruptured group. And the ruptured group had a higher proportion of patients from the highly disadvantaged tier, SES tier 5, compared to the unruptured group. When dividing the SES tiers into just 2 groups, we put SES tiers 1 and 2 in the least disadvantaged, and then 3 through 5 in the most disadvantaged. And again, there was a significant difference with the p-value of 0.028. So the unruptured group had a higher proportion of cases classified as least disadvantaged compared to the ruptured group. Outcome variables assessed included MRS at discharge and at follow-up, both of which demonstrated worse functional outcomes for the ruptured group in comparison to the unruptured group. And the incidence of death was also significantly higher in the ruptured group compared to the unruptured group. Using binary logistic regression analysis, this supported associations between sociodemographic factors and aneurysmal risk, rupture risk. Non-white patients had a significantly higher odds of rupture, as did individuals from higher SES tiers when compared to SES tier 1, which is the least disadvantaged. So individuals from non-white racial backgrounds and individuals from moderately to highly disadvantaged socioeconomic groups are more vulnerable to ASAH compared to those with UIAs. Similar to our study, Rumala et al. Analyzed other socioeconomic variables and their influences on ASAH outcomes. And in that study, they found that the presence of family or caregiver support was associated with decreased likelihood of unfavorable outcomes at the last follow-up. And the study also highlighted that having an established PCP at the time of hospital admission as the sole socioeconomic factor linked to a significantly lower risk of mortality. Other studies on race and ethnicity have shown similar results regarding ASAH prevalence. A recent study published in 2023 showed that Black patients and Hispanic patients had lower odds of aneurysm treatment compared with white patients. And then using multivariable regression analysis, they also reported that treatment odds of Black patients has improved slightly over time, but the odds for Hispanic patients and minorities have remained constant. And then Ronaldo et al. Also published a study in 2019, which showed that non-Hispanic whites had the lowest proportion of ASAH diagnosis. So health disparities within the field of neurosurgery is usually evidenced by varying patient outcomes, with certain demographic groups experiencing high rates of morbidity and mortality compared to others. Factors that likely contribute to these findings is unequal access to specialized care, socioeconomic barriers, which were highlighted here, and implicit bias. And here are some more studies that highlight the racial and socioeconomic impact on cerebrovascular outcomes specifically. And these all show similar findings to the ones present in this study. There were several limitations to the study. One, it was a retrospective review. So we had to go back through the patient charts if any of the data was not there as far as sociodemographic information or clinical information. They were excluded from the study. Also, electronic records all came from one single institution, so that limits our generalizability. And then lastly, the patient population that the study was conducted on had very few Black and non-white Hispanic patients, and therefore we had to group all of them as non-white for the analysis. In conclusion, racial and ethnic and socioeconomic disparities exist among patients with intracranial aneurysms. The study showed that non-white and moderately to highly disadvantaged patients have a higher prevalence of ASAH. And as we know, aneurysm rupture significantly impacts functional outcomes and mortality rates, underscoring the continued influence of sociodemographic factors on health outcomes. The significance of this study lies in raising awareness and addressing factors that may contribute to these disparities, and ultimately promoting healthcare equity regardless of race, ethnicity, or socioeconomic background. Very briefly, I'd like to touch on why health disparities in the field of neurosurgery are so important to me. So I'm from Fresno, California, which is like right about there. In the middle of California. And when putting my home address into the neighborhood atlas, I would fall in SES tier 5. So according to this study and many others, my family would be at increased odds of poor clinical outcomes. And I got to witness this firsthand when my sister Mariah was misdiagnosed and treated for an aneurysm when in fact she had a hemangioblastoma. So after several brain surgeries, having to travel to UCSF to get care, she ultimately passed away at the age of 18. And this experience is what fuels my passion for neurosurgery and addressing disparities within the field. Here are my references. I'd like to thank Dr. Lawton and Dr. Catapano for allowing me the opportunity to conduct research at Barrow. And then also thank you to you guys for allowing me to do a sub-I and for allowing me to present my research. Any questions?
I have one. It's a very nice talk.
Yes.
And it raises up, I think it raises even more questions than it answers. But one of them that came to mind is based on what you have here, do you have any concrete interventions that you could imagine at a public health level that would help address some of the disparities that you've highlighted?
That is a really good question. I think there are several factors that contribute to the health disparities. I think one that's important to me is really just diversifying the field of neurosurgery, just because there are some just implicit biases that we are not aware of, and having a more diverse work field would allow people to hopefully just be more aware of the biases and just provide better care to their patients.
Hey, Asha, thank you so much for the talk. Really appreciate it. So our cerebrovascular group here at Sinai actually published a paper in Stroke this year looking at subarachnoid disparities in patients. And something interesting that we found was not only in terms of diagnosis and the etiology, the pathophysiology, but that there are treatment discrepancies in terms of who is amenable to coiling versus clipping and who has access to certain types of care. So just curious in your guys' research, if you had looked at potential interventions and if you saw any disparities in terms of access to treatment in patients who undergo this disease or who experience subarachnoid hemorrhage.
So this study was specific only to microsurgical treatments, and I didn't look at anything endovascular. But I will say, I did notice that Barrow covers the majority of Arizona. So people who came from the far outskirts of Arizona, so of Phoenix, several miles away, they did have worse outcomes, and that could likely be due to just access to care. So getting to treatment in a timely manner. And also I had showed there was another study that was conducted at Barrow that showed that Black patients usually had a delay in their presentation, which contributed to poor outcomes. So I think access to care does play a huge role as well.
Thanks, nice job.
Thank you, Asha, for a really excellent talk. And I really appreciate the personal touch, sharing what drove you to look into this topic. As a cerebrovascular neurosurgeon, I see this problem play out really every single day. And I like your suggestions for trying to address it in a practical manner. I think also one thing I try to think about is trying to go do a little bit extra to try to arrange a patient with primary care if they don't have one, and maybe dedicating some office resources, a person who's going to try to find someone specifically rather than say follow up with primary care, try to find someone specific for that person, maybe even make an appointment through the office. If it might be challenging for that individual to follow up, try to break that gap between access to care when you have them under your care for a short period of time. That happens in my practice a lot because they come in with stroke and subarachnoid hemorrhage, and maybe more so than other of my colleagues, but that's kind of one thing I can think about.
Yes, I agree 100%. And thank you for sharing that.
I also think including more granular data in registries to help study this question a little more effectively than having to rely on the retrospective data that most of these studies do currently rely on would be helpful. we've generated so many robust clinical registries, but not all of them do a great job of incorporating sort of key demographic information that would help us study disparities.
Yes, I completely agree. And that is my goal, to be able to conduct these studies on larger populations and more diverse populations as well.
All right, nicely done, all three of you. And thank you for taking the time to do your sub-Is with us. We've enjoyed having all of you. I think now our next, the next thing is a resident only meeting, so everyone else can drop off except the residents. Thanks for attending today. We'll see you next week.